Hello, everyone, and welcome to today's AARC webinar. My name's Billy, I'm with Freestone, and I'll be producing today's session. Before we begin, I'd like to run through just a few housekeeping items. First, I'd like to go over the audio options for today. In order to listen, we do require you listening over your computer speakers. Please make sure your speakers are turned on and that your volume is turned up. If you are viewing today's presentation on an iPad or mobile device, you may need to scroll down in order to see the slides. Next is Q&A. Please feel free to ask a question at any time. You may navigate to the Q&A tab at the top side of your screen. You'll type your question in the box and hit the submit button to register it. We will be taking time to answer your questions today, so please feel free to ask them again at any time. If you are joining from a group, please make sure to have your group leader submit your information to the group attendance tab. If you are applying this program for credit, you will need to select 2 out of the 3 checkpoints that appear throughout the program. To check the status of your checkpoints or be directed to your education profile, navigate to the credit tab at the top side of your screen. Please note that for checkpoints to appear, you will need to make sure all of your pop-up blockers are turned off. At the end of today's event, you will return to this tab to submit for credit. If you do not see the option to submit, please refresh your screen and you will be taken through the credit submission process inside of the viewer. If you experience technical difficulties, please refresh your browser window. And should you need technical assistance at any point throughout this session, please navigate to the Help tab to find tips, tricks, and contact information for our support team. And with that, we are ready to begin. Please excuse this brief pause as I engage the recording.
This webcast and any accompanying materials are the copyright of the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with prior written consent of the AARC. Copyright 2022, all rights reserved. My name is Brian Walsh, and welcome to today's program on advanced ventilator modes in the PICU.
This webcast is sponsored by an unrestricted educational grant from Syntech.
Upon completion of this AARC webcast, participants will be able to discuss the physiologic rationale for advanced ventilator modes, discuss the evidence for the use of high-frequency modes, NAVA, and APRV in the PICU. I am pleased to welcome Mr. Andrew Miller. Andrew is a pediatric ECMO specialist and pediatric respiratory care practitioner at Duke University Medical Center. He currently serves as the section editor for Pediatrics for Respiratory Care and is the chair of the Duke Respiratory Care Services Research Committee. Mr. Miller discloses that he is the section editor for respiratory care. I disclose that I have research relationships with Vapotherm and Aerogen. Brand names of products and or medications may be mentioned only as examples of technology. Any use of brand names is not in any way meant to be an endorsement of a specific product, but merely an illustration to point of emphasis and to provide the information and education regarding the availability. Andrew, welcome to the program.
All right, yes, so thanks for having me. And the title of my talk is You Can't Stop Progress with a question mark, Advanced Ventilator Modes in the PICU. And hopefully you'll get a sense on why I put a question mark there in the title. And before we talk about advanced ventilator modes, we really need to first talk about what I mean when I talk about conventional mechanical ventilation. So I think most of us understand what this is. I just want to go over it real briefly so that we're all on the same page when I'm going over the other slides. And generally, when I think about conventional mechanical ventilation, I think of it's where the ventilator breath mimics normal breathing. So you have kind of the same respiratory rate, tidal volume, and minute ventilation that you would have if you were not breathing on the ventilator. And then also, it means that the triggering mechanisms and all the feedback mechanisms come from the ventilator and not necessarily sensing the patient directly like what you would see with, say, NAVA. And one of the things that we've learned recently, well, not super recently, the original studies were done in the 1990s, but most recently, what we've discovered is that the primary driver of lung injury is almost certainly a high transpulmonary pressure. So unfortunately, to measure the transpulmonary pressure, you need an esophageal balloon monitor. So in clinical practice, most places don't have the resources to do that. It's not certainly something we do routinely. But the nice thing about transpulmonary pressure is that the driving pressure, or the plateau pressure minus the measured PEEP, is actually almost a perfect surrogate of transpulmonary pressure in most patients. And so you can see here on this graph, to measure the driving pressure in a passive patient, so the key is that the patient has to be passive. They can't be actively breathing, or all these measurements get messed up. And you can see here you do an inspiratory hold maneuver to get the plateau pressure. Then you do an expiratory hold maneuver to get the end expiratory PEEP. And then you subtract the plateau pressure minus the measured PEEP. And that's what gives you your driving pressure. And then no talk on mechanical ventilation would be complete without this particular graph. So when I talk about lung protective ventilation, what we're really talking about is kind of a balance between overdistension and recruitment. So we want to keep patients within this safe window here, which is easy to talk about conceptually, but very challenging in clinical practice, while avoiding overdistension, which is really usually related to high tidal volumes or high mean airway pressure during high frequency ventilation. And then we want to talk that we want to get enough PEEP, or enough mean airway pressure, to stay out of the zone of de-recruitment and atelectasis. And then we generally want to target a tidal volume around 6 mLs per kilo. So the data in adults is pretty strong. The data in kids is not as good for controlling the tidal volume, but generally a target of tidal volume around 6 per kilo is where most people do. And then we want to make sure the plateau pressure is less than 30 centimeters of water. And then most recently, based largely on the Amato study, we want to try to keep the driving pressure less than 15 centimeters of water. And so what is an advanced ventilator mode? So in conventional mechanical ventilation, there's lots more modes than what I listed here, but the main ones that we see in clinical practice, you have assist control, SIMV, pressure support. Then those can be pressure targeted, volume targeted, or servo regulated. So this would be like PRVC. And then when I talk about advanced ventilator modes, it's any mode that delivers the breath in a non-traditional way. So high frequency ventilation, so this would be high frequency oscillatory ventilation, high frequency jet ventilation, high frequency percussive ventilation, neurally adjusted ventilator assist, or NAVA, airway pressure release ventilation, or APRV, and then proportional assist ventilation, or PAV+. So I'm not going to talk about PAV today because I wasn't able to find any published literature on PAV. There have been some studies in the neonatal population, so it's definitely feasible. I just couldn't find anything that's been published. And then the million-dollar question is, who may need an advanced ventilator mode, right? So the vast majority of our patients don't. And so one of the things we think about is patients who are unable to, you can't maintain adequate gas exchange with a conventional ventilator. So I would define this as an SaO2 less than 85%. And this is for a period of time, not transiently, probably, a half hour to an hour or 2 hours sometimes, or a pH less than 7.20 with an elevated PaCO2. And as I get further on in my career, this pH level that I'm comfortable with gets lower, and the CO2 levels I'm comfortable with gets higher. And then other reasons that you might need an advanced ventilator mode would be you have adequate gas exchange, but you have to use non-protective ventilator settings. So you have a plateau pressure of 35, you need 100% FiO2, but your gas exchange is okay. So you're worried about toxicity from high FiO2 or high airway pressures, and then that's where you would probably transition to some sort of high frequency ventilation or APRV, depending on what center you're in. And then air leak. So there's quite a few centers and some data that says that you can use high frequency ventilation for air leak syndromes. And then prolonged mechanical ventilation, or patients with a lot of patient ventilator asynchrony, that's where you can use NAVA or PAV+. And kind of the principles of high frequency ventilation. So the things that we think about would be the tidal volume is always lower, or not always, is usually lower than anatomic dead space, so it's less than 1 to 3 mLs per kilo. The respiratory rate is much higher than normal. It can get up as high as 900, depending on how you manage HFOV. And then gas exchange is achieved through multiple complex mechanisms. I'm going to talk a little bit about them on the next slide, but generally how it works is you end up with, during high frequency ventilation, this is a figure from jet ventilation, you end up with this kind of steady flow of gas that goes through the center of the large airways and the conducting airways. And then the CO2 kind of twists around the outside of this kind of flow stream to clear CO2. And that's one of the reasons that instituting a cuff leak is so effective at increasing ventilation during high frequency ventilation. And then the three main modes that are available. So we have high frequency oscillatory ventilation. That's been the most used and the most studied. High frequency jet ventilation can be used in the PICU, but there isn't a whole lot of great data. And then high frequency percussive ventilation, again, is used fairly frequently, largely in burns, but we don't have a ton of great data to guide us. And so really quickly, I'm not going to go over these in depth, just in the interest of time, but the main mechanisms of gas exchange during high frequency ventilation, you're going to have bulk gas flow, streaming of gas flow. And you can see this is a nice graphic because you have gas going in this way, gas going out the other way kind of at the same time. And when they're superimposed together, you end up with this kind of gas going in this direction and then out the other direction kind of at the same time. Then you have Pendelef, where the gas will flow to one alveoli and then kind of overflow into the others. Taylor dispersion, cardiogenic mixing, which is actually where the heartbeat actually helps exchange gas, and then molecular diffusion along concentration gradients are all mechanisms of gas exchange during high frequency ventilation. And so first up, we're going to talk about the oscillator. So the oscillator uses a frequency between 5 and 15 hertz. As I said earlier, the tidal volume is around 1 to 3 mLs per kilo, but it could be even lower or higher depending on how you have it set. It uses bias flow to maintain the mean airway pressure. And then it clears CO2 using a piston that displaces gas to and from the patient. So you can see in this graphic here, illustrates this very nicely, that you have a high pressure at the airway, and you have pressure going in and then pressure going out. So the machine pushes the air in and it pulls it back out. And you can see in this graphic, as the gas or the pressure goes from the trachea to the alveoli, the pressure attenuates or decreases quite a bit as you go through the respiratory system, which at least in theory provides pretty good lung protection, which means that you're going to have theoretically at least a low transpulmonary pressure in the alveoli. So this is theoretically quite lung protective. And then during HFOV, the oxygenation and ventilation are relatively independent. They're not completely independent, but oxygenation is largely controlled by mean airway pressure and FiO2. Then ventilation is controlled by the power or the amplitude, and then the frequency. And then during HFOV, the tidal volume is affected by the frequency and the power, but frequency has a much larger effect. So if you increase the hertz by 2, this decreases the tidal volume by 21%. In contrast, if you increase the amplitude by 10, it only increases the tidal volume by 5.6%. This was an in vivo study, so that's very interesting that in terms of when we talk about tidal volume delivery during HFO, this is can be considered kind of a surrogate marker of transpulmonary pressure somewhat, and that if you go up on your hertz, you're going to decrease your transpulmonary pressure, which is one of the potential limitations of some of the adult randomized control trials. And then increase in inspiratory time percentage also increases the tidal volume. So we usually run our HFOV at 33% I time with the SensorMedics device, but you can increase it up to 50%. But when you do that, you improve CO2 clearance, but you also increase the transpulmonary pressure and the tidal volume. So there's usually a trade-off between improving gas exchange and lung protection. And then tidal volume is also affected by the size of the ET tube. As the tubes get smaller, the tidal volumes get smaller due to resistance from the tube. And then importantly, pressure transmission is actually highest in patients with low compliance and low compliance and low resistance. So patients with ARDS or RDS who have low compliance but low resistance, there's more pressure transmission from the oscillator, which means that it might not be as protective as we think. And then finally, when we talk about lung recruitment, higher frequencies during HFOV result in better lung recruitment. And our goal is to set the frequency at what they call the resonant frequency of the lung. And it's a very complicated way to set the oscillator. The problem is that lung injury is very heterogeneous. So you end up with, relatively healthy lung units and then severely injured lung units. What you end up with is the resonant frequency of the injured lung might be 12, but the healthy lung is 4, and you're trying to figure out what's most protective for the lung as a whole. And that's a very complicated thing to try to figure out, even in computational models and bench models. So it's probably something that's not quite ready for clinical practice just yet. And now on to the clinical data for HFOV. It's primarily been used in severe ARDS, which the adults would define as a PF ratio less than 150. In peds, we define it as an OI greater than around 16 or so. And there's lots and lots of studies in adults, including the two big trials, OSCAR and OSCILLATE, that were published back in 2013. and they have not shown any mortality benefit or any really benefit at all other than improved oxygenation. But some of the subgroup analysis and post hoc analysis for HFOV have actually found that there might be a benefit for the really severely injured patients. So the patients with the PF ratio less than 64, maybe there's a benefit to those patients. But if your PF ratio is higher than that, some of these individual patient meta-analysis actually show that it's probably harmful, not beneficial. And that's adult data. So the PEDS data, again, we have a systematic review that was just published last year that, again, found no mortality benefit, no difference in time on mechanical ventilation, no difference in barotrauma, but definitely improves oxygenation. The contrast between adult and pediatric data is that the pediatric data is really not very good. So we don't have nearly as good of trials. The largest trial to date enrolled 200 subjects. A lot of the early trials are quite flawed because the control groups didn't get lung protective ventilation. And some of these groups, the control groups actually had PIPs in the 40s and up to the 50s. So it's fairly hard to interpret those data. Luckily, we have some more recent pediatric data, not randomized control data, but some pretty good propensity score match studies, which is a fancy, complicated way to do a case control study to account for various confounding variables. We actually have 3 recent studies. So one is from the virtual PICU system database, which showed increased mortality if you were placed on HFOV. The Pac-Man study group from Singapore found the same thing, increased mortality with HFOV. And then a secondary analysis of the RESTORE trial found no difference in mortality, but a decrease in ventilator-free days. And so if you're unfamiliar with ventilator-free days as a metric, a lower number is worse and a higher number is better. So if you die, you get a ventilator-free days of 0. And if you come out off the ventilator on day 1, you get a ventilator-free days of 27. So a higher number is better. And then a really nice paper that's published, I guess, 3 years ago now from Martin Nijberg's group in the Netherlands. They actually described a different kind of method for managing HFOV and pediatric ARDS. So most centers, including ours, we usually manage HFOV. We use a fixed hertz, and then we use the power or the amplitude setting to adjust the CO2. And what they actually do is they actually start with a hertz of 12. They maximize the power or the amplitude, and then they control CO2 by going up and down on the hertz with the goal of getting the hertz to be as high as possible. And so they think that this is more lung protective, and the animal data would support this as well, that this is more lung protective potentially than the fixed hertz or the fixed hertz and controlling the CO2 with the power. And then they couple this with a really aggressive de-recruitment maneuver to define what they call kind of the optimal mean airway pressure. And so despite this very complicated maneuver, their published data actually has mortality data that's very similar to what's been published in other studies. So it's not totally clear if this is a superior method for HFOV, but it's really important that we understand that this is the strategy that's being used in the prospect study that's ongoing. So in summary for HFOV, it definitely improves oxygenation. Whether this translates into long-term outcomes, we don't know. Based on adult data and most observational studies, probably improving oxygenation in the short term doesn't improve on long-term outcomes. What its role in pediatric ARDS is unclear. Its role as a rescue mode has not been well investigated. So most of the randomized control trials are not enrolling patients who are failing conventional ventilation. They're just enrolling patients with severe ARDS. So like I said in one of the previous slides, maybe if the PF ratio is less than 64, and this comes from adult data, they didn't include an OI cutoff in these recommendations. And with a little luck, Prospect will give us an answer, but they've only been able to enroll 116 patients as of last week. So it's not totally clear if this study is going to be completed. My guess is that it's probably not going to be, because they're trying to enroll 1,000 patients over a 5-year period. We're already about halfway through that. So we may not get an answer for Prospect, but I'm still hopeful. So on to high frequency jet ventilation. So jet ventilation is high velocity gas. It's delivered using a pinch valve. And this pinch valve creates a flow stream of fresh gas that helps clear CO2. So you pretty much have a continuous fresh supply of gas going through the alveoli. And then in contrast to HFOV, it's a little bit lower rate. So you end up, instead of, you have 240 to 660, which is 4 to 11 hertz, versus, you can be as high as 15 hertz on the oscillator. Then you can see in this graphic, again, what you end up with is you have a high pressure at the airway, so you have a high PIP at the airway. But in contrast to HFOV, the end expiratory pressure is never going to be below what you set on the ventilator. And then as you can see here, it attenuates pretty significantly through the respiratory system, which again, similar to HFOV, should at least theoretically result in a low transpulmonary pressure in the airway. And then the other challenge with the jet ventilator is that you have to use a backup rate or sigh breaths to kind of help recruit the lung, which can result in elevated alveolar pressure, even if it doesn't interrupt the jet at the airway. And then we can adjust so on HFOV, you set the I time, or you set the IDE ratio. On HFJV, you set the I time, and then the IDE ratio is a resultant from what you set this at. And then mean airway pressure is controlled primarily by PEEP on the conventional ventilator. And then unfortunately, our commercially available devices are kind of limited to kids about 10 kilos. It's possible to use them on kids that are bigger than that, but we haven't been able to find a whole lot of good published data. So generally we say around 10 kilos or so is kind of the upper limit for who you can use the jet on. And then how we adjust jet ventilation. So one thing that comes up even in our center where we use the jet a lot is that people think that it's similar to HFOV, in which when you adjust the rate, it adjusts the tidal volume, which is not how the jet works. So as long as your delta pressure is the same, the tidal volume will be the same. The only caveat to that is if you have significant air trapping, then you will get a higher tidal volume when you go down on the rate, in the same way that you would if you had, say, an asthmatic patient with a prolonged expiratory time and you went down on the rate on the conventional ventilator, you end up with a higher tidal volume because there's more time for exhalation. And how we usually define air trapping is if the measured PEEP on the jet is 1.5 to 2 centimeters higher than what we set on the conventional ventilator. And then what we usually see in the PICU compared to the NICU setting is you usually have to increase the inspiratory time, usually to 0.03 seconds in order to get adequate ventilation. We usually need to set the backup rate of at least 5. At least in our study that we did, we weren't really able to we weren't able to identify any patients where we were able to consistently have the backup rates at less than 5. And then it's really important to remember that oxygenation is controlled by the mean airway pressure, which if you want to improve your oxygenation, you need to increase PEEP. You can also increase the number of recruitment and sigh breaths, but you have to be cautious about this because if you increase the backup rate above like 8 to 10, you can get significant air trapping, which can result in potential barotrauma. And then also a thing to remember is the jet's not PEEP compensated. So if you increase the PEEP, you also have to increase the PIP by the same amount to make sure that your ventilation stays stable. Then clinical studies of jet ventilation. So we don't have any recent randomized controlled trials in the PICU setting. We have one older study in patients with air leak that showed a reasonable benefit to jet ventilation, but the control group had PIPs in the 40s to 45. So it's really probably not applicable to modern practice. So we really don't know if the jet's better for air leak than simply lung protective ventilation. And then unfortunately, there's very little good data published. There's certainly no meta-analyses available. So what we have is kind of 3 recent small single center studies, largely in kids with viral respiratory failure that are failing conventional mechanical ventilation. So the first was from Valentine and 12 kids with RSV. And what they found was they had improved CO2 clearance, but no effect on oxygenation. They had a pretty high survival rate in this study, I think 92%. And then our first study in our PICU, which was, we took all kids that we put on the jet that weren't on ECMO. Most of them had viral bronchiolitis. And again, we found the same things. We had improved CO2 clearance, but no real improvement in oxygenation that we can detect. And then we looked at our kids with congenital heart disease. And again, we found pretty much the same thing. So we get better CO2 clearance, so their blood gases improve in the short term, but we aren't able to really detect or see any sort of oxygenation benefit over time. And then we have quite a bit of older animal data that says that, the jet can help in air leak syndrome. It has a favorable hemodynamic profile. This is largely related to the fact that you can ventilate with a lower mean airway pressure, so you can get good CO2 clearance with the low mean airway pressure. So this is potentially very advantageous in patients with passive pulmonary blood flow, so like a patient status post-Glenn, for example, or a patient who can't tolerate a high mean airway pressure due to hemodynamic compromise. So those are the potential applications of it, but I don't think it's widely used in terms of patients in hemodynamic compromise, even at our center that uses it a lot. So in summary, the use of the jet's really rare in the PICU. There aren't that many centers that use the jet in the PICU. It may have a role in refractory hypercapnia from viral illness, air leak syndrome, as a strategy to improve hemodynamics after cardiac surgery, but that's kind of speculative on my part. We don't have very good data. And I think, unlike some of the other modes, we really need to focus on probably a large multi-center registry of jet ventilation in the PICU, because there's just not enough centers that do it. So I think the odds of getting a good randomized controlled trial are very low, but at least if we got a big registry study, we could get some sort of sense of how to use the jet in the PICU, because it's really kind of unclear at this moment. And on to high frequency percussive ventilation, or the VDR. So this is used mostly in burns and smoke inhalation. So you have maybe a benefit to those patients in adults, but it's not totally clear that there's strong evidence that the VDR doesn't in fact improve outcomes. And this is a pneumatically powered time cycle pressure limited mode. It has high frequency percussive breaths that are overlaid, 200 to 600 breaths per minute over top of a conventional mechanical ventilation breath, generally at a 1:1 to IDE ratio. So, but you can use it in other IDE ratios if you want. And then the number of conventional breaths varies based on how big the patient is. So the smaller patients get more conventional breaths per minute. And then the PIP and PEEP are set by the machine, but the machine actually uses the mean value, which I'll show you on the next slide. It actually uses the mean of the percussive breaths at each pressure level. And so you can see here, this is the phasotron. This is where the magic happens. This is what creates the percussive ventilation. And you can see here, even in this particular circuit setup, this is not a humidified setup, which is one of the limitations of the device, which I'll talk a little bit later. But what you see here is you have percussive breaths at PEEP or P-low or whatever you want to call this. And then you see how it, kind of bounces around 10, but they would probably call this 10. And then they would call the PIP 10, or sorry, the PIP would be 20, even though you can see here the pressure clearly goes up above 20. And then as the lung kind of fills slowly early on in the breath, it then is potentially completely filled. Then you have percussive breaths on top of that. So you have potentially, at least theoretically, a potentially high transpulmonary pressure during inspiration here that may not be lung protective. And this is just another graphical representation about what I talked about in the last slide. So you'll hear people talk about how the VDR is lung protective because the tidal volumes are low, but it's important to remember that the tidal volume is going to be from this inspiration. So that when this red line goes vertical, and then all the gas that goes in during that breath, and then when the exhalation phase starts, all the gas that goes in and out during that phase is going to be the tidal volume, not the individual percussive volume. So I think it creates confusion, especially in clinical practice, because you really can't measure any of this stuff at the bedside. Even in a lab with very advanced machines and very, very smart people, it's still extremely difficult to measure because you have gas going in and gas going out at the same time. So it's very difficult to kind of quantify how much gas is going in and out when the machine's in use. And then, as I've already kind of touched upon, the mode is very complex. So because it's pneumatically powered, there's no microprocessors. So when you set things, so when you set the inspiratory time, for example, you don't set it at 0.6 seconds or 0.8 seconds or 1.2 seconds. You turn a dial that goes from 1 to 12. And then every time you turn that a little bit, it's going to affect potentially all of the other things on the machine. So you adjust the inspiratory time a little bit. You then have to mess with the expiratory time. If you turn the PEEP up or down, you have to sometimes adjust the inspiratory time and the PEEP and the PIP. And there's a lot of kind of art to it as opposed to science, which makes it very, very challenging. It's very, very difficult to measure or to manage at the bedside. And because it's so complex, it creates a very high workload for respiratory therapists. So there's some centers that actually staff the VDR 1-to-1, which means that if a patient goes on the VDR, there's an RT that stays in the room with them all the time, similar to how many centers staff VA ECMO. And then one of the big limitations of the device is that, like I said in the previous slide, you can't measure the tidal volume, and you can't, and then a very limited alarm package. So if something happens to the patient, the machine's just going to keep going. It's probably not going to tell you that, say your patient has a tension pneumothorax, you're probably not going to be able to detect that, whereas you would with some of the other modes. So clinical data for high frequency percussive ventilation, like I said, we do have some reasonable data from the adult burn patient population that says maybe there's an advantage to VDR over lung protective ventilation, but it's certainly not a super strong signal there. We don't have any pediatric randomized control trials, which is true of the vast majority of things that we're talking about today. And to be honest, most of the things that we do every day, we don't usually deal with a lot of high quality randomized control trials. But what we do have are some case series, case reports, and one before and after study from CHOP. And what they generally show is that you get an improved PF ratio and better CO2 clearance. So you improve your gas exchange acutely, which is good. But most of the studies that we were able to find don't consistently report the OI or the OSI. So it's a little bit harder to interpret that whether this improvement in PF is related to the higher mean airway pressure or the machine itself. And then the before and after study in ECMO actually did show an improvement in ECMO-free days, which is a metric I have not seen in any other papers, but no difference in mortality or ventilator-free days. And I think it's really important that if you're considering getting a VDR and applying this in your ECMO patients, that this study came from CHOP, and they have a lot of clinical experience using the VDR. They have a lot of institutional experience, so they have a lot of experts on how to manage the device. So I think if you were to purchase the device and try to use it, you're probably unlikely to have the same outcome, especially early on, because there's a fairly steep learning curve to the device. And then similar to most other high frequency modes is that animal studies don't show any advantage to high frequency percussive ventilation over protective ventilation, but it's probably better than non-protective ventilation. And then bench models, like I said, reveal high tidal volume. When we talk about high tidal volume, we're talking in the 15 to 20 ml per kilo range, which is well outside of what we would consider lung protective. So remember, our target that I talked about early on is around 6 per kilo, which we have pretty good data from adults to say that that is what you should target to kind of optimize outcomes. And then, like in any pressure mode, tidal volume is resistant or is sensitive to changes in compliance and resistance. So if your lung mechanics change, your tidal volume and gas exchange will change as well. And then one of the biggest purported benefits of the VDR, high frequency percussive ventilation, is that it's reported to improve secretion clearance. So there's lots of people that say you put them on the VDR, you're going to get a ton of secretions out, it's going to be great, the patients are going to do great. We weren't able to find anything in the literature that supports that this is in fact true. There's a few case reports, a couple case series of 1 or 2 patients, but we really can't find any objective data in the literature that says that the VDR is better than any other device or any other strategy for airway clearance. So we're not totally sure if this is actually true. And then one thing to remember with the VDR is that it doesn't provide very good humidity because of the way the phasotron works. So one of the big challenges is making sure that you get enough adequate humidity to the gas that goes into the patient. And if you have problems with secretions and you're not getting adequate humidification, you can actually have worsening secretions because they'll now be thicker and harder to get out than with a conventional ventilator. So it's not totally clear that there's actually an advantage to the VDR in terms of secretion clearance. And then similar to the jet ventilator, we really probably need a multi-center, like in a perfect world, we could get a randomized control trial, but I think that's probably unlikely. What we really need, again, is a multi-center prospective registry study that's really recording lots and lots of values in terms of safety, efficacy, and who benefits and who doesn't benefit, and those types of things that are currently missing from the literature. And then in summary for HFPV, it's a very complicated mode. It probably has some utility in burns and smoke inhalation. The tidal volume is well outside of what we currently consider lung protective ventilation. And then its role as a rescue mode is unclear. It seems to improve gas exchange acutely, but with other modes, we really don't know if this improvement in short-term gas exchange will translate into improved outcomes over time. And then, so we still have 2 more modes to cover. So we're going to switch from high frequency ventilation to airway pressure release ventilation. And this is a time cycled pressure controlled SIMV, generally used in an inverse I to E ratio, but it can be used in other I to E ratios. And one of the main features is the patients can breathe throughout the entire cycle. So if you can see on this third graph down here, you can see P high or PIP, and you can see the patient clearly breathing on top of that, which is not necessarily advantageous. And then you have a release phase that clears CO2, and it goes back up to the P high, and the patient can spontaneously breathe. And then ventilator companies have done a pretty reasonable job of designing them so that if the patient's trying to breathe during the release phase, it will either delay the release phase or not allow the the patient to spontaneously breathe during the release phase, but we really don't know what happens when the patients try to breathe during the release phase. But when we talked about transpulmonary pressure early on in one of my early slides, the major concern with APRV is this: if you have the lung inflated at P high and the patient's spontaneously breathing, the end inspiratory transpulmonary pressure is the P high plus whatever effort the patient makes, plus the tube compensation if it's set, and plus the pressure support. So just because your P high is set within the lung protective range, so your P high is set at say 30 or 26 or 28, if the patient's spontaneously breathing, especially if they're vigorously spontaneous breathing, your end inspiratory transpulmonary pressure could be well outside of what is considered safe. And then to date, it's been mostly used as a rescue strategy. And then I'm going to talk more about the pros and cons on the next slide. So the pros and cons of APRV. So the pros, you get improved lung recruitment and improved oxygenation. Both of these are related to high mean airway pressure and may not be specific to APRV, but more related to the high mean airway pressure. You get improved VQ matching, which again is not necessarily specific to APRV, but it's something that you see in spontaneous breathing patients. You usually get better VQ matching with spontaneous breathing patients. And then reduced sedation, although unless it's part of the trial design, most of the randomized control trials have not shown reductions in sedation needs in APRV. The only studies that have shown a difference are the ones that had it as part of their study design where the APRV patients wouldn't be as sedated. And then the cons, the biggest one is you can't control the tidal volume. And so even in lung model studies, by Rob Chapman and Eduardo from the Cleveland Clinic and some other places, they can't control the tidal volume even in passive lung models. So, and that's makes it even more complicated when you have an actively breathing patient. You have atolect trauma during the release phase. So even if you set the peak expiratory flow at 10 K at 75%, you can still have atolect trauma because the sickest lung units, as in the ones with the lowest compliance and the highest resistance, which is what we see in ARDS, those are the lung units that are going to empty the fastest. So they're going to collapse and reopen every time there's a release phase. And then, as I said on the previous slide, you can have a high transpulmonary pressure during spontaneous breathing. And then it's also a very complicated mode with lots of disagreements on how to set things and how to do things, and even lots of disagreements on how to define things. So adult data. So we do have a meta-analysis in adults that shows improved outcomes with APRV, but it's really important to remember that this meta-analysis was very flawed because they included studies where the control groups did not receive lung protective ventilation. So it's not really a fair comparison to say APRV did better than non-protective ventilation because pretty much every mode we've gone over so far has performed better than non-protective ventilation. So we really don't know. We really need better clinical trials if we can get them. And then there was a study that did show improved outcomes. The Zhao study from China showed an increase in ventilator-free days and a mortality benefit, although it wasn't designed to detect a difference in mortality. But the important thing about this study is actually two things. One is that they set the P low to 5, as opposed to some APRV advocates have spoken very strongly that the P low should be set at 0. And then the other thing that was really interesting is they actually had their respiratory therapist titrate sedation in the APRV group. So I forget what the exact percentage was, but they had a percentage of the minute volume that was going to be spontaneously breathing in the APRV group. And then the ARSNet study group was kind of deeply sedated. So it's not totally clear if the benefit there was APRV itself or the sedation strategy or a combination of both. And then more recently, since that study was published, we actually had 2 studies that were stopped early by the Data Safety Monitoring Board. The first was the Hirschberg study. It was stopped because they couldn't control the tidal volume in the APRV group. And then the other one was in COVID, was Ibarra Estrada, and this one was stopped due to increased mortality. So I think we can't really overstress that even though, and when you look at these trials, the mortality didn't reach statistical significance, it's really a huge deal that these trials are stopped early. That means that an independent board felt it was unethical to randomize more patients to APRV in both of these studies, and that's why they were stopped. So I think it's a big deal that these trials are stopped, which makes it hard to support using it clinically still. And then in the PICU, unlike most of our other modes, we do actually have a randomized control trial of APRV compared to lung protective ventilation. And just like those adult studies that I just mentioned, this study was also stopped early by the Data Safety Monitoring Board due to higher mortality in the APRV group. So even after they controlled for some minor differences in baseline characteristics, APRV was still associated with double the risk of mortality. So if you put your ARDS patients on APRV, you're actually doubling their risk of mortality in the ICU. And you can see here on the slides, hopefully you can see it, but the groups are pretty reasonably well matched. So the tidal volumes are pretty similar throughout. The mean air pressure is a little bit higher in the APRV group, which is by design. That's part of the trial. Also by design is the APRV group was spontaneously breathing more, which also was by design. And you can see here the PF ratio. You can see here that the APRV group is maybe a little bit sicker here, right? So the PF ratio is a little bit lower at enrollment, but at 12 hours, they're basically identical. And then over time, they're basically identical here, even up to 72 hours. Then the OI is higher at baseline, but then once you get to 12 hours, it's a little bit higher in the APRV group, but it's only 1.5, which is probably not a huge difference. So you have two groups here that are pretty reasonably well matched. And despite that, APRV showed a increase in mortality. So we have one other prospective study in the PICU, and this was a crossover study in kids status post cardiac surgery. They had tetralogy of Furlow repair, Glenn or Hemi-Fontan. So for those of you who aren't familiar with Glenn or Hemi-Fontan, those are two patient populations with passive pulmonary blood flow. So mean airway pressure is not their friend. And what they found is that APRV improved pulmonary blood flow, but they only observed this when the patients were spontaneously breathing. So this is something that you'll also see in just regular patients. Once you let them spontaneously breathe, they'll get better pulmonary blood flow just because of the negative pressure from spontaneous breathing kind of pulls blood into the heart and allows better pumping. But really importantly in this study, they didn't find any change in SpO2 or other measures of oxygenation. So just they had better pulmonary blood flow, but everything else that they measured was the same. So there doesn't seem to be any real advantage that we could see in this study. And then really importantly, when we talk about alveolar trauma, the pleural pressure was almost always negative during the release phase in this study. So it went well below zero, which means that they're potentially exposed to alveolar trauma and collapse and reopening. And then retrospective studies of APRV, there's lots and lots and lots of studies. They're summarized in our article in Translational Pediatrics. And what they usually find is the oxygenation improves, so you get a better PF ratio. They don't consistently report OI or OSI. They generally report a lower PIP, but it's important to remember that just because the PIP is lower or the P high is lower than the plateau pressure was, that doesn't necessarily mean that your patient is more protected, because the transpulmonary pressure could still be quite high. And then one of the major limitations with APRV literature interpreting the clinical trials is there's just a huge variety of settings and methods. Every study does it a little bit differently. There's certain groups that advocate very hard for their method of, including giving courses and webinars, that their method is better, but we don't have any head-to-head comparisons about this is the way APRV should be versus this. And there's a lot of controversy, and there's some very vocal people out there that have very strong feelings. And when you read the literature, when you read about APRV, they're all dogs, like in this picture, but they're all different dog breeds, and these differences in the breeds might be significant, and they may have an effect on outcomes. And when we talk about controversial things with APRV, the things that are really controversial was P low. So some groups advocate for setting the P low at 0, and then you use the peak expiratory flow to kind of create auto PEEP to maintain alveolar recruitment. And then this strategy is what was used in the Ibarra study with the higher mortality. And then T low is set to maintain this peak expiratory flow rate at 50 to 75%. And then P high is also controversial. There's some groups that advocate you should set it at the plateau pressure you had on conventional mechanical ventilation. Others say you should set it at the mean airway pressure on conventional ventilation. Others say you should set it on, just right at 30. And other people say you should set it 2 to 4 above the mean airway pressure on the conventional ventilator. We really have no idea because we don't have any comparative studies. We also really don't have any good data to suggest that we should be using APRV necessarily at all, nonetheless, to investigate these subtleties in management strategies. So this is my summary of APRV. I think it's associated with possible harm. I think you could sell me on that it's actually probably associated with harm based on the Gannison study and the two studies that were stopped early in adults. And I would say use it very cautiously outside of a clinical trial. So if you're part of a clinical trial, use it at your will. And if you do use it, I would say to set the P low at least a 5, based on what they did in the Zhao study. to kind of help reduce this atalic trauma. And it'll also help you control the tidal volume. And finally, our last mode is neurally adjusted ventilatory assist. So this is a mode that is proprietary to one ventilator company. And what it does is it synchronizes to the electrical activity of the diaphragm. So you put in this kind of specially made custom catheter. It has a bunch of electrodes here. It's in the esophagus, and then it measures the depolarization of the diaphragm, which means that it senses immediately when the patient wants to take a breath, and it senses immediately when they want to stop taking a breath, and then it will also adjust based on the patient's effort. So that if the patient takes in a stronger effort, it gives them more support. If they take in kind of a weaker effort, it gives them a lower support level. And so it's very useful in terms of patients that are potentially difficult to get off the ventilator. Then it can be used both invasively and non-invasively. And I think when we talk about synchrony during mechanical ventilation, one of the things that the biggest causes of dyssynchrony are triggers, so trigger delay, and then cycling criteria. So those are the two major causes of dyssynchrony are issues with triggering, and then where your neural inspiratory time and the inspiratory time on the ventilator are different, and that creates dyssynchrony. And you can often see this, especially if you use SIMV. And then if you put the patients in NAVA, you can see almost immediately how much more comfortable they get once you're kind of synced up with their neural inspiratory time. And then, so adult data, we actually have 2 randomized control trials. One was from Bob Kazmarek. It was published 2 years ago now. And they enrolled patients that were expected to be on the ventilator for at least 3 days, so 72 hours. And Bob Kazmarek's paper actually found an increase in ventilator-free days, which was their primary outcome, which is good. And then the patients spent 3.3 fewer days on mechanical ventilation, but there was no mortality benefit in this study, which you wouldn't really expect there to be much of a mortality benefit. But the goal here is to get the patients off the ventilator sooner. And then the other study actually did show an improvement in mortality. But unfortunately, in this one, they showed 4.9 fewer days on the ventilator, but this wasn't statistically significant because it was a pretty small trial. I think it only enrolled, I think 80 patients total. So it was pretty small, but it also showed, a pretty significant effect size. It wasn't quite statistically significant, but potentially a real effect once we had the Kazmarek study published later in the same year. And then pediatric data. So we do have a meta-analysis of NAVA, which makes us think that we really have some good data for NAVA use. Unfortunately, most of these studies were short-term crossover studies. So your patient was on pressure support or SIMV or assist control, and they put them in NAVA for an hour or sometimes 2 hours or sometimes even only 30 minutes, and then they kind of measure the synchrony. What they do find is that you definitely have improved synchrony. You have lower PIP, but not necessarily a lower transpulmonary pressure. Increased SpO2, which is largely related to a decrease in work of breathing, and improved VQ matching. And then, as you would expect, the patients don't need as much sedation, and they're more comfortable because they're more synchronous with the ventilator. And then we do have one single randomized control trial that didn't show any difference in time on mechanical ventilation, but they did find a reduction in ICU length of stay with NAVA, which is kind of strange. You wouldn't expect the patients to leave the ICU sooner if they didn't get off the ventilator sooner. But what's really important in this trial is that the patients were not on the ventilator for very long. So they were only on for 3.3 hours for NAVA and 6.6 hours in the control, which means this is a patient population that probably doesn't need NAVA. You can usually probably just do your normal ERTs or SBTs and extubate them when they wake up. And there's mostly post-operative patients. So these are patients who probably don't need NAVA. We certainly can manage most of them without it. And then despite this, they again show better synchrony, lower PIP, and higher SpO2 in NAVA patients. And then these effects are also seen in kids with congenital heart disease, and it also has an improvement in hemodynamics, which again is probably related to improved synchrony and better VQ matching. So in summary for NAVA, it's definitely safe. It definitely improves synchrony. It's maybe beneficial to liberate difficult patients. The adult data would say that it is. Peds, we don't know. We need a big randomized controlled trial. It's almost certainly going to be helpful to do non-invasive ventilation or BiPAP in small children because we don't have any good interfaces or machines that can allow good synchrony for these smaller kids. So I think NAVA is potentially a very valuable tool in these kids. And then, like I said, we're going to need large randomized controlled trials of both invasive and non-invasive NAVA. And unfortunately, that can be a challenge because you can only have the one ventilator that does it. And then in summary, for all of our modes, so every mode is very complex. Kind of went over these briefly, but most of them are even more complicated than I mentioned. The learning curve can be very steep, especially if you're using some of these things for the first time. The evidence supporting most of these modes is very weak. There's also publication bias. So if you're not familiar with publication bias, this means that people are more likely to publish their positive results and less likely to publish their negative results. So if somebody had, say, used APRV and had an unfavorable experience, they're not going to most likely publish that. And it would be the same thing for the jet ventilator or the VDR or even NAVA. So I think we probably don't have a entirely clear picture of what's happening clinically because people aren't publishing their negative studies, or if they've had adverse events. Hopefully Prospect will give us an answer for the oscillator. I'm not optimistic that that's going to happen because enrollment's been quite slow. And then we need large multi-center collaborative studies, either registry studies or even some, short-term, maybe trying to think of the right word, kind of where, we just need some large studies of maybe like everybody that use an advanced ventilator mode for a month or something like that, and kind of see how people are using it and what the outcomes are. And then thank you. Almost all of this information is in our recent review article. It's open access. It's free on a narrative review of advanced ventilator modes in the PICU. You can email me with complaints or comments or concerns, and you can follow me on Twitter. I only tweet about work, and hopefully we have some time for questions.
Yeah, thank you, Andrew. There are a couple of questions in there that I think we may have answered, but I'll just throw out one from Charlie Brooks. Is there an advanced mode that's any better than conventional modes? And so,
I think that's kind of the $1 million question. So I'd say in adults, we have some pretty good data that says if your patients are going to be on the ventilator for more than 3 days, that NAVA is probably a pretty good choice to get them off the ventilator sooner. In terms of the other modes, I would say in oscillator, probably not. The jet, we don't know. And then VDR, we don't know. And then APRV, I would say definitely not. And we have probable harm in several clinical trials now for APRV. So I think using APRV is probably harmful in both adults and kids with ARDS, at least based on the published data. I hope that answers Charlie's question.
Yeah, and then there's one more in here that just came in. Does NAVA work better than with different ventilators? And the answer is no, right? In other words, it's only a McKay or Getting, I guess it is now.
It's only on the servo ventilators. So unfortunately, to do a large clinical trial, you'd have to have centers that either already had this mode, or you'd have to bring the ventilators in and teach them how to use the ventilator. So there's a lot of logistical challenges with using NAVA.
Yep. And one that we run into quite often is post-pyloric feeds. In other words, if they wanted to use, say, a deep NG tube feeds, it won't work in that situation because the electrodes are too far away from the diaphragm.
Yep. Or you have to have two catheters in. You have to have the NG tube and the NAVA catheter, which creates problems with interfaces for non-invasive ventilation.
Exactly. All right, I think that's it.
I wish we had better data to talk about. That would be nice.
It's a tough lecture to give for sure. All the pediatric data is a lot of times pretty hard to come by, and so please join us for the next broadcast on January 21st for the 2022 Journal Cast presented by Michael McBeck. And then on February 2nd, Jackie will be presenting ethical failures and impacts on medical mistrust. So thanks once again for joining us.
Great. Thanks, Brian. And again, a big thank you to Andrew for sharing his excellent presentation. And all our participants, thank you for your excellent questions as well. If you're a group participant, please have your group leader submit your information to the group attendance tab to be provided with follow-up instructions on how to submit for credit. If you have any questions, please email crce@aarc.org. This does conclude today's presentation. To submit for credit, please click on the Credit Submission tab. Once finished, you may simply exit out of your browser window. We all hope you have a great rest of your day.